So imagine for a moment that you have an appointment with a new healthcare provider. You completed the online check in, which includes lots of paperwork asking who are you, your history, any medications you're taking, how you're going to pay, and the like. You notice that no question was asked about your sexual orientation or identity. As someone that identifies as gay, you're already feeling pretty invisible before you even get to the appointment. It doesn't help that you are well aware the medical profession has a history of discriminatory practices and beliefs toward those who are part of the queer community and often lacks training related to how to be affirming. As a side note, I use queer as an umbrella term for LGBTQ, as there are many more identities, and I don't want to group those all together into a plus sign. I realize for some that this is not a good choice and they don't like queer, so I want to be transparent about why I'm using that. Back to the story. You're now in the exam room, and the doctor comes in and does a brief history and exam, basically confirming the information you provided on your intake forms. They did not ask about your sexual orientation. They then go on to ask if it's okay to send in an intern to do a history as part of their training, and you agree. The intern comes in, you're surprised they actually asked about your sexual orientation, and you share that you're gay. This makes you feel a little bit more seen and comfortable. The doctor returns and the intern shares the information from their history, including that you're gay. The doctor stops, looks at you, and then states, "We will order an HIV test." Importantly, not once did they ask if you knew your status, if you had recently been tested, were you even sexually active, with whom and how many, about your safe sex practices, including if you take PrEP preventatively or anything. How would you feel? Actually, this is part of my story, and frankly, I was pretty pissed. The point here is that many health organizations and many of its practitioners often unintentionally engage in microaggressions or even discriminatory behaviors due to the lack of training and awareness. Each time I and many of my queer siblings go to the doctor or other healthcare provider, we have to prepare ourselves to likely have a negative experience and question, do we even want to go? This presents a major barrier to access and is related to a variety of queer disparities in health and well-being. This episode explores ways to help those in the queer population find affirmative healthcare providers as one way to mitigate some of those systemic reasons for queer health disparities. Our guest organization is Garden State Equality, who shares some of their experiences developing and launching their affirmative healthcare map for New Jersey. Welcome to Collabolutions, a health equity podcast. I'm your host, Dr. Brad Van Eden-Moorfellow, a professor and the Senior Diversity, Equity, and Inclusion Fellow in the College for Community Health at Montclair State University. In each episode, an interdisciplinary group of guests from local community organizations and across the College for Community Health team up to explore why some people experience challenges to their health and well-being more than others. We collaborate on creative solutions that bring us closer to making sure all people, families, and communities have access to opportunities to be as healthy as possible. Come join us on a journey for health equity and justice. I have a phenomenal group of people joining me as guests for this episode, and it is a privilege to have Garden State Equality as our community partner this time. Let me tell you a little about them. Brielle Winslow-Majette serves as the Deputy Director of Garden State Equality, which is the largest LGBTQ+ advocacy and educational organization in the state of New Jersey, serving all 21 counties. Brielle was named on the Insider NJ's 2022 Insider Out 100 LGBTQ Power List, and since has overseen many initiatives helping to bring awareness and solutions to multiple inequities affecting the LGBTQ+ community. Layla Orlando is a passionate registered nurse who has served underprivileged communities for over a decade with the goal to create opportunities for all. She currently serves as the Director of Health Equity and Wellness at Garden State Equality, a position she believes can empower others to not only break stigmas, but become an advocate for equality. Rosemary DeSteven is the Senior Clinical Supervisor at the Montclair State University Center for Audiology and Speech Language Pathology in the Communication Sciences and Disorders graduate program. Prior to her 19 years in the role as clinical educator, Rosemary was a medical speech language pathologist at Children's Specialized Hospital and University Hospital. Rosemary's most recent areas of interest are in providing voice training service for transgender and gender diverse individuals within the MSU and local communities. Amanda Birnbaum is a professor and deputy chair in the Department of Public Health at Montclair State University, where she has been part of the faculty since 2005. She earned a PhD in epidemiology from the University of Minnesota and a Master of Public Health from the Mailman School of Public Health at Columbia University. She seeks to understand and improve social environmental factors, such as school and neighborhood environments, as they relate to health, social justice, and people's thriving. So I am in awe of the wealth of experience, the background, and the successes that you all have had, as well as the work you've done to support and amplify the queer communities. I thank you for being here today, and I'm looking forward to this discussion and see if we can come up with solutions. For our listeners, let's start with a little background information about Garden State Equality. Brielle and Layla, I would love for you to share a bit about Garden State Equality generally, but also about your health and wellness programming unit specifically. Brielle, do you want to start us off?
Absolutely. I think I knew you were going to come to me first, so I can take it away. For most people who've heard about Garden State Equality, they knew us as a marriage equality organization. We started about 20 years ago, knocking on doors, galvanizing New Jersey citizens and residents to say everybody deserves the right to marry. We fought hard to pass same-sex marriage here in New Jersey and to bring awareness across the country. With that being said, we are a completely different organization than we were back then. Our next challenge was to look at how can our organization be a post-marriage equality organization, and how do we accomplish lived equality for everyone? So one of those things is we are a part of the Equality Federation, which is a national organization. And through some of our work through inclusive curriculum and anti-bullying policies, we've actually paved the way for the nation to follow New Jersey and how to tackle those issues in their own states. But right here in New Jersey, our inclusive policies and us trying to fight towards lived equality comes in three pillars of how we accomplish those things. One is legislation. We can't do the work that we do without the backing of inclusive lawmakers and elected officials. To date, we have passed or helped to pass over 260 pieces of legislation to make sure that New Jersey residents are protected, and anybody who's coming to our state also, be it that New Jersey is a sanctuary state currently. Some of those pieces of legislation, since we are talking about healthcare, is with the help of Hyacinth and so many other local partners. We helped to decriminalize HIV, which is major. And we also were able to pass the LGBTQI Senior Bill of Rights, which helps to make sure that our older LGBTQ adults are recognized and also safe in whether that's long-term care and also in the healthcare space. With that being said, our next pillar is really education and youth development. And so we provide trainings on cultural competencies, how to be an ally, anything that you can think of when you're thinking about the isms and how to show up in lived equality in multiple spaces. That could be universities like MSU, that could be places like a healthcare space like Hackensack Meridian or RWJ. And then also those are in schools. So we're on the ground and hopefully to be one day all 600 school districts across the state of New Jersey to make sure that we are showing up and letting the youth know that we're here, we see them, and we want to make sure that the policies in their school settings focus on them. Since then, we've created two camps. One, Makers Camp, focused on youth becoming the advocates they want to see in their communities and joining us to really think about what are those isms, what are your own self-biases, and how do we move forward? And then also a gender-affirming fashion camp, because we know that there are youth who don't find clothes that fit them. And I don't mean fit them as in the size. I mean fit them in terms of their gender, in terms of how they want to present, in terms of how they want people to breathe them in and to take them. We are truly working on all facets from elementary age to senior adults to make sure they are seen in the state of New Jersey. One of our biggest pillars is health, equity, and wellness. I would be remiss to start talking about that department myself because our director of health, equity, and wellness has done an amazing job since she started with us. So I'm going to let her get started talking about that department in particular.
Hi, everyone. Like Rial said, my name is Layla Orlando, and I'm the Director of Health Equity and Wellness at Garden State Equality, which I'm really excited about. We have a lot of programs that we put on and help cater to the LGBTQ plus community. Brad, I know that you said that you like to use the word queer, as do I, folks who are also identifying as queer. We have a lot of programs in our health and wellness department. So we have tobacco cessation, which helps folks stop smoking. We do a lot of work, like Riel mentioned, with Hyacinth, and part of that work was helping to decriminalize HIV here in New Jersey. We do a lot of work with folks living with HIV and programming around that. We also have vulnerable populations that we take care of. We put on programming for folks who are houseless, folks who are older adults. Everyone forgets about the older adults in our community. And unfortunately, they are just as much a part of our community as everyone else. And then, which we will be talking about a little bit more later on, which I'm really excited about, is the healthcare affirming map, which is super important to the work that we do. The healthcare affirming map is a map where you can go online and you can find LGBTQ inclusive healthcare providers, which again, we're really excited to talk about a little later on.
I'm always so impressed by how much Garden State Equality does. And I feel that you're so connected on the ground and ahead of where the needs are, but also understanding where they need to go and where we need to push boundaries and the realities of today. So I'm really appreciative for being able to have you all here, share what you're doing, let others learn from that, but also brainstorm together. One of the other things that I'll mention, Brielle, I love the use of the word lived equality. Because I think so much, at least in some circles, we talked about lived experience, but this idea of lived equality really spoke to me. So I'm going to use that a lot going forward, but I'm giving credit to you every time I use it. I love it. I think what I'd like to do is provide some research information on things I found when digging around, preparing for this, and then have a little bit of a group dialogue to see our different perspectives. In looking at stuff over the past few years, there seems to be an increasing number of news reports about people across the US being more likely to avoid going to the doctor, like upwards of 40% or so. And this is the general population. And there's several research studies that find similar rates to these news reports, with some being higher and lower. So most explanations suggest cost and access drives this avoidance, with fear and anxiety of a negative diagnosis closely behind as reasons for not going to a healthcare provider. For those that are part of the queer community specifically, rates of avoidance are often higher, including some studies that suggest about 60% or so will avoid going to healthcare at some point. Their experiences with providers, including reports of being disrespected, being misgendered, having their sexuality blamed for the medical problem, being ignored, are just a few examples. There are studies that also suggest that many in the queer community have positive experiences too, even if most report going to the appointment with an expectation of experiencing discrimination or lower quality care. So a lot of times you just have the expectation that it's not going to be good. But once you get there, sometimes it does turn out to be good. And that's a good thing. For those that do go on to have a negative experience, they also report that their health became worse, likely because they didn't return to that provider ever again, or maybe not another one. So as I think about my story and those in the queer community who might also be transgendered, non-binary, people of color, immigrants, disabled, and additional intersecting identities, all with unique health circumstances, the need for affirmative healthcare is so important that it will save lives. Let me state that again. Literally, affirming healthcare can help save lives. That's my perspective, but let me ask you all. Help me understand the need for queer affirmative healthcare.
I think that gender affirming care, I think it's really important, first and foremost, to realize that it's not a one size fits all. When you're thinking about healthcare, one of the most important things is that it is a person that is walking through that door despite their intersectionalities and their lived experience, and they should be treated as such. Each person is a delicate space with delicate needs. When we go back to what you said about lived experiences and talk about Garden State Equality, one thing that I mentioned is our mission statement. This is what we reflect as to what we should see in healthcare, is that we want to uplift diverse voices of LGBTQ communities. And when we talk about communities, we also acknowledge that there could be multiple communities on one singular block that have completely different needs. And I think as the healthcare space starts to understand that, we're not grouped together. Like the L doesn't have the same needs as the T. And even within the T, they don't have the same needs. It is not a one size fits all. And that for someone, that could just be as simple as using their pronouns correctly, or understanding based on their identity what their healthcare goals are and how they are actually assisting them to get to those goals instead of telling them what is needed for them to actually be able to be themselves and to be healthy and affirmed as themselves. So I want to start with that premise that it isn't a one size fits all. It is not just the medical portion, but it is also the interaction between individuals that come into spaces, and that it is, you don't have a playbook, but there are some concepts. And if you think about treating each person like a separate entity that there's no rule book on, and also not being afraid to make a mistake, but being humble enough to correct yourself if you do, and humble enough to get the explanation for why, I think that is the foundation of making sure people feel like they're seen in the healthcare space.
Rosemary?
So what this really made me think about is the general ethics of care. And Riel, when you were talking about really listening, attentiveness is one of our general ethics of care. So being attentive and making it individualized for that person, our responsibility as healthcare professionals, and like being responsive. And we need to develop for gender affirming healthcare competence. Like this goes back to competency. What does that look like? It's not just, oh, I watched this, I did this course on it. It's really that lived experience or lived equality. And I think the last that made me think about was really responsiveness, like being that responsivity to our patients that will hopefully create this environment for this.
As I was listening, I was thinking about how, in terms of many of the isms, care that sees and affirms individuals helps everyone, right? It's beneficial for everyone. And so I think right now, it's really important to have this map, because there's so many people who understand, as you were saying, like before you go to the doctor, understanding this is what's out there. This is what I'm likely to experience. Am I really ready to put myself out there? And I want to say, Brielle, to add to the alphabet, I think the A spectrum has a whole additional set of assumptions that get put on them at doctors' offices. Not to mention, Brad, your story, another counterpart of that is the pregnancy test. Your last menstrual period, people say you could be like emerge from a burning house and, you know, everything's on fire and you're breathing fast and you get to the hospital. And the first thing they're going to ask is, when was your last menstrual period? And, you know, people not respecting that, people know how people get pregnant, right? People know how one gets pregnant. People know if they have been in a situation where they could or could not get pregnant. And I think that particularly affects people who are on the spectrum, asexual, agender. The idea of attentiveness makes me think about curiosity, that so often, you know, the idea of curiosity is really a way in to be more inclusive, because we don't know all the categories and isms in advance, but with attentiveness and curiosity, I think I dream of when the map isn't needed, because it's not like a niche issue or a boutique issue. If we can just sort of use the shared strength and experiences of the communities intersectionally. As I mentioned, I have a real interest in the neurodivergent community, which has such a strong overlap and intersection with queer communities, including the A spectrum. And I think using this process to lift up inclusive, affirming practices can help everyone.
Hearing everyone speaking is kind of giving me, I mean, everything that everyone has said is so correct. Amanda, you mentioned about pregnancy tests. And as someone who identifies as a lesbian, the first question I always get asked at a doctor's office is, are you pregnant? I disclose my sexual orientation. And they're like, okay, well, we're going to do it anyways. And it's definitely frustrating in that sense. But affirming healthcare, just in general, is about intersectionalities and making sure, like Brielle said, that it's an individualistic process. Everyone is different and everyone's needs are different. From the BIPOC, Brad, you asked a question about people having negative experiences when they're going into medical offices or healthcare providers. For the BIPOC community, that may be very different. It could be extremely triggering just based off of cultural differences alone. And then you talk about terminology, and pronouns are super important, but terminology is also extremely important. When you're at an OBGYN and you're talking about reproductive health and you have a trans man in the office and they're waiting to get seen just as equally as someone who identifies as a cis woman, terminology is also super important when we're talking about gender affirming care. I would never want to say to someone, oh yeah, breastfeeding when it's chest feeding. And, really misgendering isn't the only way that we can harm someone by our words. Just some thoughts to add into the group discussion as well.
I think that a couple of things that you all said that I just wanted to touch on was that one of the things you said, Amanda, was like that it's a niche issue. And I think that we have to bring to the light that also education views it as a niche issue. So until the education behind becoming an MD or becoming an RN or anything of that nature, number one, doesn't treat the LGBTQIA lens as just one entity or any of the other intersections. So until they break it down and actually are looking at what things are, and we know that there's so many issues with that, like research, SOGI data, like these are things that are just now coming to the light that are allowing for people to see what is actually the lived experiences of individuals. But we're going to continue to have a map, in my opinion, until education doesn't treat LGBTQ healthcare as a niche issue. But I think one of the things that Layla said and Brad, you said to bring to light is the intersectionality. Like for Black women, the biggest stereotype that you hear is that Black women feel like they are unheard when they go into the healthcare space. People don't believe that they have the pain that they're having. They don't believe, like they're telling you what's going on. They're asking for preventative care and they're ignored in many spaces. So if you imagine being a Black woman and then also being on top of that LGBTQ, or even take it a step deeper in being a Black trans woman or a Black and brown trans woman, you already have the lived experience that nobody's going to believe me. And now you walk into a space and I'm dead named or misgendered or, asked a question that makes me feel uncomfortable despite me already filling out the paperwork that could have been read that told people what my pronouns are. I think that that is the biggest issue. But then also just zooming out in the education space, we also are in a space where education is based on what state you're in, what legislation is there. So if you're in a state that doesn't believe in gender affirming care, you better believe that doctors are not learning about what that is. And that is down to what pronouns are because you can't even say them. So I think that there's a lot of structural issues that's not just like what is gender affirming care, but what are the laws and implementation surrounding that? Because like I said, education on this issue should not be niche. It should be universal. Also, it should be something where LGBTQ individuals and also individuals with those intersecting identities, even neurodiversities, should be at the table helping to create the competencies that Rosemary spoke about.
Yeah, I love those points. You all are having my brain go in so many different directions. This is amazing. I've done several trainings on how to update an intake form to make it more inclusive, not only with sexual orientation, gender identity, but in several other areas. Because most intake forms, they won't ask pronouns or they won't ask or differentiate like legal names, your dead names, and your name now, right? Or so many other things, or they continue to have a question about race, but it always lists white first, privileging white, and that sends a message. Or if they ask gender, most will include male and female as the only two binary reinforcing options. And which one is listed first? Male, even though female should be first if we're going alphabetical, which is kind of the way to be inclusive. So it's the smallest little things. And they send that message right from the beginning that feeds a lot of these expectations. But I think too, what I'm hearing across several of you is part of being competent, responsive, all of this is also where the education needs to have every provider in training and in practice take deep dives into their selves to really figure out what they know, what they don't know, what their biases are, unconscious and conscious, and start with there so that can spread out to where there is an ethic of care that is respect across everyone, that takes time to really get to know people, which insurance companies wouldn't like because it produces less money. So again, it's a systemic issue that gets feeded in.
As I'm listening to this, I want to clarify, because I think that some of the points I'm making from a public health perspective sound a lot like points people make from an exclusionary perspective. So when I say this should not be niche care, what I mean is every provider should be coming into the room with an open mind as to who this person in front of them is and what their needs are. What I'm saying is it should be just part of the standard norm with which people walk into a room about sexuality, about gender, about neurotype, about race, ethnicity, etc. I guess that I want to be clear that I'm not arguing the universality from an all lives matter perspective, which I worry that it sounds that way. What I'm saying is the opposite, is that everybody has lots of different issues and it shouldn't be perceived as a special issue. The real thing I was going to say is that I also think that we're not starting from scratch. So I really like the book and the play Wicked, the tagline, "A lot happened before Dorothy fell in." And I think that we really need to bring that into our care and into the way that we train people, and not just providers, but people who are administrators, people who are patient facing, people who work at insurance companies and make decisions, right? It really needs to be for everybody. And the people are already traumatized. So each additional microaggression that happens, each affirmation like that is re-traumatizing people. It's not neutral. It's not like, the person's coming into your office with a blank slate and about to establish their relationship with healthcare overall. And in particular kinds of situations, the response of a public-facing person can be a big piece of what you were talking about, Brad, why somebody might or might not decide to go get health care. And I have a colleague who did a study where she had people calling pediatricians' offices to see if they could take a new patient. They used census data to use names that were most common names for white kids, for Black kids, brown kids, and it won't surprise you that there was more availability to take patients when they used the names that were the top names for white kids born in the year of relevance. Those things are already happening before someone might even get into the room for the encounter.
I'd like to move now into the particular MAP initiative that Garden State Equality has launched, and then kind of move forward from there. I really think that the affirmative healthcare map has moved the needle in our community here in Jersey and really provides such a model for others across the world. Brielle and Layla, I would love if you could give us a quick overview of what is this map? How does it work?
So I'll let Layla talk about the logistics, but I do quickly want to say, for all the reasons you mentioned, Brad, this was created. We were on the ground with other local institutions like RWJ, finding out what people's lived experience was, shockingly for most. And I love that Amanda talked about and also clarified, because a lot of times when like-minded folks speak, we all understand what each other is saying, but the people who are listening who aren't like-minded, we assume that they know. A lot of people didn't think this was even needed. They were like, these healthcare disparities don't exist. Individuals aren't being treated differently. But the unfortunate part is, like, they don't understand the different nuances of how these individuals are being treated differently. Garden State Equality got in front of a large challenge called on local partners, which is what we do, to make sure that we are getting everybody's in the room and that we have the best of the best to think about how do we make change. And then we went about the methodology of being like, okay, let's make sure that our trainings have the competencies that Rosemary talked about in terms of what are we providing? What is it that people need to know? What is the manner that people need to follow to try to make sure that these individuals know what it is that someone's walking in and looking to receive? After about a 2-year process, our project manager, Jamila Smith, was pivotal, along with Jay Wu, our comms manager, who did amazing work to put together this tool. And it's only gotten better since Layla has joined our team. So I'm going to let her talk about the logistic part and how it works, and then shed some light on that.
Thank you.
Yeah. Okay. So essentially, if you are looking for an LGBTQ inclusive healthcare provider, that can be primary care doctors, any type of specialist, a mental health therapist, any type of behavioral resources, essentially just anything that has to do with health and wellness. If you are someone from the LGBTQ plus community looking for one of these providers, you can go online to our map. You can either put in your insurance, your zip code, what you're looking for, and it'll give you all of the options of providers statewide here in New Jersey who are on our map, who have either been trained by us or like-minded organizations that talk about the points that Brielle mentioned, Rosemary, some of the things you mentioned as well. Essentially, there are a couple forms on our website. If you are at a provider or a doctor that you feel is super inclusive and would like to add them to the map, there's an option for that on our website. If you go to a doctor and you have a terrible experience and you're like, oh my God, these folks could really benefit from your services, from your training, we reach out to them and we're like, hey, we can offer you a training. Like, this is who we are. This is what we do. We've gotten some feedback. Let us help you better understand your patients, understand those intersectionalities, and get the ball rolling. If you go to a doctor on our map and have a great experience, we encourage you to review it for us. This is exactly what we need. So currently we have over 282 providers on the map. We continuously add more every month. We are trying to hit 350 by the end of the year, 400 if we can get there. We're also offering those trainings in Spanish and adding providers who speak Spanish to the map as well. So something else that we're really excited about. So that's like the overview of the map.
That's amazing. Can you talk a little bit about some of the trainings you offer to help people be able to go through that and be added to the map?
Yeah, of course. We have different trainings that we offer corporations, hospitals, nursing homes, things like that. So it's our LGBTQ 101, 201 series. It kind of just talks about inclusivity, who we are, what are some challenges that the LGBTQ plus community faces, some statistics in terms of why pronouns are so important, microaggressions. We talk about intersectionalities and how to be an ally, how to be an effective ally, because sometimes people are like, I'm an ally, but are you an effective ally? Are you really advocating for people in our community? So we offer a bunch of different trainings. We tailor them to that organization. So if we're giving a training for a mental health place, for example, those statistics about depression and suicide and generalized anxiety disorder would be more heavy based, as opposed to us giving that to the front desk staff at a nursing home where their training is more focused on microaggression, pronouns, and things like that. So some of those are the trainings that we offer. Sorry if I'm talking too fast. I get excited when talking about the map.
That's amazing.
Could I chime in?
Yeah, please.
Yeah, two things. One thing is Layla laid out perfectly like trainings, but trainings aren't the only thing that people need before they get on the map. We also have a vetting process for the individuals who are on the map. We look at their website because we know that even if someone's not using our website, but someone's finding that individual, there's little key things on your website. Like, it's important to name that you have LGBTQ services. It's important to have the little like logo that has a little rainbow, not just during Pride Month, so people know. Those subtle things allow for them to feel safe. There's definitely a vetting process in terms of calling that space and having a questionnaire and having them answer questions that let us know that they're inclusive. Or if we can't get in contact with them, also looking at their website. And if we don't feel like those things reflect the criteria needed, we will provide recommendations and say, I'm sorry, we cannot accept you on the map at this time, and we need you to change these things before we can do that. And that also has happened. So yeah, the trainings are the most important part, because that's how you learn to actually interact with the individuals who are coming in. But there's also a vetting process so that people aren't just saying, hey, I got trained by an organization that we've never heard of, and that we get to look at the criteria before we say, hey, you are a safe space. Because Brad, you said gender affirming care saves lives, and we understand that this map is a serious tool to ensure that people continue to get care.
Absolutely. Snaps for that. Rosemary and Amanda, what's your response? What questions do you have, or what do you just think about this amazing tool that has become available for Jersey?
It's so incredible. Before coming onto the podcast, I went on your website and I was looking to see how many speech pathologists are actually listed, and there's not enough. And I want to be on that list. You're already giving me food for thought of like, I definitely want to talk with you guys about what we can do on our website to make sure that we are gender affirming. But I think, first of all, there's such an overwhelming need for this map. And I just know from the trans community, the queer community that I've worked from my patients, they're always looking for resources and they just don't know where to look. I brought up Garden State Equality. I think Montclair State students went for a field trip for trans visibility, and making an assumption that they might know about that, and they don't know they don't even know the organization. So I think finding more safe spaces, specifically for university students, but anyone in the local community, is super important. And what that also does within our clinic and with our community, our small community we have there, it just connects people. And that can be so empowering. We obviously have groups on campus and they allowed me to come and talk about our services, but we're really trying to provide more of that connection. And I think, like you said, Layla, putting those reviews up there, if they had a really positive experience, you want to know that too, so that those individuals can go on your website and say, okay, I know this person had a good experience. I feel good about going. So I think it's incredible. I'm super excited about it. And I want to come to your training.
Amanda, do you have any thoughts?
I do. One of the things as we're talking is I keep hearing in my head, like, get on the map. Get on the map has a bigger meaning, but here it really is, like, we want to get more people on the map. I also looked and I was impressed to find some providers near me that I'm not familiar with. I think there's two pieces of the vetting that I find really, really critical. One is that you're using it as an outreach tool, which is so positive. Instead of saying, nope, you don't cut it, we can't put you on our list, I hear you framing it as, we would like to reach out to you to help you better understand. So almost like the assumption that people will get on the map, and maybe the assumption that everybody wants to get on the map, I know is probably not true, but I think that projecting that assumption is a helpful way to change norms, right? Like, of course you want to be on our map, and really creating that demand. And I also want to echo what Rosemary said in terms of the value of the feedback, both positive and negative. I think that sometimes initiatives like this fall down because they get up on the website, and then there isn't an ongoing assessment or accountability. A practice gets sold, a provider leaves, staff changes. As you were saying, as everyone was saying earlier, LGBTQIA+, there's diversity within each letter, let alone across the letters. So maybe it's an LT friendly practice, but they need a little bit more help on some of the other populations and communities. And so I think the fact that you're taking it seriously as a healthcare tool and keeping it dynamic is something I haven't seen a lot of people do, and it's very exciting.
Some things I'm hearing, it kind of takes us into, how do you take this wonderful tool and then really increase its impact and reach? You have to have capacity for that, which is very difficult because that takes both people and money and connections. So Brielle and Layla, do you have any particular challenges to overcome to really grow this and let your vision for 20 years from now come to life for the total impact that this tool could have, as well as its reach across into other states?
I can start. I think I have a laundry list, but I'll keep it short. I think one of them, as a deputy director, I look at things from a bird's eye view, and you hit the nail on the head in terms of capacity. I want to remind everyone that Garden State Equality is a nonprofit. When I first started, I've been here for 2 years, there were only 5 staff members, not including myself. By the end of this fiscal year, we'll probably have almost 20 staff members. If you rewind to the beginning of this, when I talk about everything that we do, that's not 20 staff members dedicated to health and wellness. That is 20 staff members that are taking care of the legislation, taking care of the health equity and wellness, taking care of one pillar that I did not say, and oh my gosh, it bleeds into health equity and wellness, is also like adverse childhood experiences and communities healing together. Individuals with adverse experiences, which I think that was my second point, talking about neurodiversities. When Layla talked about trainings, we also talk about the fact that healthcare disparities are tied into adverse childhood experiences, and how some of the challenges that people have with their health starts from when they're young, and what that environmental factor is. So that's also a part of some of the trainings, and we are also working to merge those so that healthcare providers are more aware of these are some of the things you might be facing. Because if you look at the rates in research too, there's a lot of correlation between certain intersectionalities and adverse childhood experiences and health disparities, along with so many other things. Capacity is really one of them. I know you asked about a challenge. Do I have to wait to say the solution, or can I speak about a solution because Amanda and Rosemary kind of talked about it already?
Let's go for it.
I think that we need universities who have students who are eager to do research to be the ones who are stepping up to say, hey, Amanda, you just talked about somebody's research being calling these places. Like, us having students that might want to do the vetting process and help us with the vetting process. Last summer, we had an individual who came from Vanderbilt who was gender diverse, and they helped us call individuals and actually map things based on their lived experience. So we need universities that are looking to find some of these social deviants and to come in here and do research with us. We would be able to provide internships to vet this process and really be like, hey, how do we make this happen? I think number 2, we also have a challenge with geographical location and capacity. We are currently in Asbury Park, and there are people from Cape May. That is a long drive. And there are people from Sussex County. That's also a long drive. Being able to have individuals who are also creating spaces and talking to providers in those spaces is a challenge, because it is a lot for us to be in all of those spaces and still in the spaces that we're at as well. So we do have some challenges with accessibility in terms of we know South Jersey needs more representation. We know that there's providers out there, but they have no idea what those resources are. We need to make sure that we're getting into those spaces and expanding access on the map and just in general.
Brielle, I was getting ready to say, boy, do we have some interns for you. And I will follow up on that. But I also think, we've talked before about the idea of potentially partnering in different ways. And this is a way that I would like to have some follow-up conversations, because I think there's a lot of overlap. It can be student volunteers. I think there's also a lot of what you're talking about that we're teaching, and that it can be in our classes. It doesn't have to be, we can model that this is something that's built into the structure. It's not a volunteer only kind of activity.
Rosemary?
And I just really, we really, in terms of education, really thinking about this generation coming up, thinking about my own children. My daughter's a senior going off to college, and like, they're informed. I'll go to her and I'll ask her, what is this term? And she's on it. It's just automatic. It's part of her vocabulary. And I think we've got to think about our university students and really instilling this in them. They want it. So I think, as Amanda said, there are so many opportunities to get students involved. They would be more than willing, and they are going to learn so much about the importance of gender affirming care through all of this. So I think there's so many opportunities. I'd love a follow-up discussion as well.
I'm just going to jump on that really fast to say that part of that learning process is that some of the students we will be including are students who have some of the same needs that we're researching and accessing. And so it sort of reinforces that. I have a friend who likes to say, instead of encouraging empowerment, which makes it sound like we're giving people power, to expect entitlement, right? Like, I'm entitled to have gender affirming care. The more we build it in as an expectation, the more it supports people in showing up with that expectation.
Yeah. No, that's such a great point. I like that. Riel?
If I could just say two more things, and just one on the university tip, because we are here. A lot of times universities, and I will say in my response to my interactions with MSU in the last year, we went on MSU's website, listed Garden State Equality as just a marriage equality organization. As much as it's important for us to update our website and our map, we looked at them and we were like, wait, what? Like, and I think that like sometimes universities, and I'm not saying MSU only, but like RWJ, like Stockton, William Patterson, they remember that like it's not so localized either. Like you really should be in contact with statewide organizations. Some students live across the state and when they go home for the summertime, and the resources that you're providing when they're only looking at localized organizations does not help them when they go home, because they need someone who they can also transfer that kind of care to, or to have the same level of care. So I think that's a big one. But I think the last thing I would say is a challenge is that on an education level, and we know this from being able to work with youth, they're also not being taught their own ways to deal with healthcare, although they know the terms, and you're so correct. But the amount of youth that come to us based on what district they're from have not learned anything about LGBTQ care. They're still going to health based on what their biological sex is assumed to be. That is still a major barrier in the implementation of education for these youth individuals, for them to see these are future doctors. If you start them now to see that you can't look at their own healthcare that way, that's going to change the way that they view that when they get into the profession. So it starts so young, like Rosemary said earlier, and like Amanda, I know you know, it starts so young. And until our elementary schools and high schools are also following suit and making sure that what individuals are being taught changes, we are still going to have a leg of this race that we're not paying attention to.
Yeah, that's such a great point. It shows how systemic and pervasive all of this is, because nothing happens early on. If you lack that perspective, then when you're in that position, it's so much more difficult. Layla, you were going to say something?
Brielle made a really good comment about folks not being taught their own health. I just wanted to make a point that a lot of people don't know that tests look different for everyone. As a registered nurse and someone who's worked in LGBTQ plus clinic before, when a person who identifies as gay comes into our office, the way that we may test them may be completely different the way that we test someone else. We may be testing for different things. If someone is on PrEP, which is prophylaxis for preventing HIV, or NPEP, or any of those things, we look for their liver enzymes. We look at their kidneys, depending on what medications they're on. A lot of people don't have the information because they've stopped teaching it. I just wanted to put that out there, that if you are advocating for your health, you should be advocating for your health in all facets of it, and just, doing the education and the research.
And I think going along with these ideas that we're talking about here, and Layla and Brielle, specifically for you, but certainly Amanda and Rosemary as well, if you think about the types of information to infuse in the curriculum, so that by the time a student got to the internship stage, they would have enough of a background to really jump right in. Are there a couple of pieces of info that would be most helpful for them to get before showing up for an internship? For me, I want someone that understands queer history, the basics of it, the historical discrimination that has happened, the traumas that many people experience, not even in depth, but can you acknowledge that there is a history there and that matters? So for me, that's one thing that I think is really important as a personal perspective. But Brielle, I think you were going to say something first.
Yeah. So I think my lens is going to be a little different, actually, because I read most of staff. And I personally believe that when you work in a space, and I think this holds true for healthcare too, when you work in a space helping people, there's so many things that I can teach. I can teach you the history. I can teach you how to have bedside manner. I can teach you how to be culturally competent, but I can't teach you your moral compass. And I think that when people are coming to our internship, we ask questions about, what is your definition of anti-racism, and how do you stand for individuals? Like, have you been an ally, and what does allyship look like to you? Because we need allies just as much as we need people. But I think, like, For me, any intern that's coming to gynecology has to understand that, for one, although we're an LGBTQ organization, the intersectionalities of all people are at the forefront of everything that we do. And if individuals are unable to be accepting and to understand those individuals, there's no reason we can't go any further than that right there. So I think that is the biggest. I can teach you whatever you need. I mean, capacity wise, maybe not, but I can teach you whatever you need. But you have to already understand the general foundation of why gender affirming care is important because of your own personal beliefs and values and moral compass before you can even do more. So I think that is imperative.
So a part in the curriculum, or several parts really, that helps them do kind of that inner reflection to figure out where are they with their thoughts and beliefs. That really ties back to that humility piece, is looking inward so that you can actually see people for the strengths they bring to the table, who they are, especially as experts of their own experience in the world, and be able to honor that.
I was going to say, and I do want to highlight, as a person who teaches LGBTQIA policy, like, we do not forget to talk about the years of stigma that has led us to the healthcare systems that we have, the policies that we have, the notions that this is an exclusionary process and only affects certain individuals. So I do want to say that the healthcare piece and the stigma behind it in the history is also so important.
So I was just going to add, when looking at things, someone who approaches the internship with compassion and a trauma-informed mindset. Trauma-informed care can obviously be taught in terms of personal development and trainings and things like that. But someone who's always thinking about these people that we're serving, especially in health and wellness, a lot of the folks that we service are vulnerable populations. So someone willing to understand trauma that folks are going through and meet them where they are. Brielle likes to use the term parachuting. We don't need people to come and parachute into community. Here's something that's going to solve something for 15 minutes and then, okay, bye, we're never going to touch base again. A lot of the programs and initiatives that we have, a lot of the work that we want to do and are doing are long term. We don't want to just go into a community and be like, hi, we're here to help for 15 and then we're gone. Someone who can come to the table understanding that there's a lot of different intersectionalities at the table, a lot of different issues that need to be addressed, and just someone who's compassionate enough to be like, okay, I understand you, I see you, and I value you, I think is probably the most important to me.
When Brielle was talking about the experience of Black women not being believed about their health, I think it's critical to say that is a big problem right here in New Jersey. And we have one of the worst disparities in maternal death in Black pregnant people and all other pregnant people. And so much of what happens, and you see this nationally, I mean, you can just read story after story of women saying something is not right. People, or pregnant people saying, or birthing saying something is not right, something is wrong, and being sent home and being reassured and not heard. There's the story I read of a Black woman who was a doctor who kept saying, there's something wrong, wasn't listened to, she passed. And so it's not, it's not just academic. It's not, these are, like you said, Brad, it's life and death. And I think that that's a gender and race intersection across any gender identity and sexual orientation. A birthing body, if it's a Black birthing body, it's not safe.
I just want to add to Amanda's point. Amanda, thank you so much for bringing that up. Maternal mortality is something that I am extremely passionate about. Black women or Black carrying bodies are 245 times more likely to die giving birth than someone who is considered white. So that just goes to show into perspective. As a nurse, like working on labor and delivery, we do have a scale that we use in order to tell if someone's going to have a C-section or if someone's going to give birth vaginally. You get -2 points just for being someone who's BIPOC. So it's really important, especially for our BIPOC community. I talked about stigma and culturally how Black people have consistently been undermined. We saw during COVID, a lot of people were nervous to go to the doctor and get a vaccine that could potentially save their life because of the discrimination that they faced in the healthcare system previously. I just wanted to touch on the fact that Black folks are still dying giving childbirth, and the US is trying to do things about it. It's still very important and definitely needs to be talked about more.
No, and I think that really, that's been another thing that's come up so much during our time together today is really, the queer community is not a monolith. There's so many other intersectionalities, which means that really any part of training, whether it's in curriculum in universities or people in their offices, has to also address intersectionality. What is that? How that matters, how that co-informs and co-shapes someone's experience as queer in the world. And I think that that, as well as these connections that can help grow capacity, are two really valuable things to consider, not just here, but in rolling this out in other states so that you build a stronger community to do this work together. Earlier on, before we started recording, we mentioned that's another systemic issue. The system created this mess, but the people who are affected by the mess have to do the work to create it. And that's such a problem in and of itself with this and so many other things, including the fact that the maternal deaths of those in Black bodies. I mean, that really is such another issue and will probably be a future podcast. I think that's a good place to stop today. I think we got some good ideas going and some wonderful information. So I'd like to again thank each of you for taking time to do this episode, to really talk about this and the work that you're doing to help the queer community. If any of the listeners would like more information about Garden State Equality, please visit www.gardenstateequality.org. I'd also like to mention all the ideas shared here represent those of all the individual guests and not necessarily Montclair State, the College for Community Health, or Garden State Equality. Thank you to each of you for being here today, for sharing your wisdom, for brainstorming, and for the work that you do. See you next episode. Take care.